me on one thing. We were talking about the gas and oil and federal lands and such as that. And I don't know, and maybe many of us don't know. On the federal lands, whether it's timber or it's mining operations, gas and oil or coal or whatever, we are the property owners of that land. Do we get anything from the sale of those minerals?
Yes.
And how much is that?
Each is different. So minerals. So the answer is yes. We get royalties and lease payments. So first you get taxes. Just regular taxes. But when we let or bid out contracting for timber, for minerals, for energy, you get a lease payment up front to the federal government, and then you get mineral payments. You get royalty payments and stream of income. And so, for instance, in our highway bill, we're saying if we open up some of these locked up areas, now we're not talking about pristine wildernesses. We're talking about up in the coastal tundra in Alaska, some of the intermountain region, some of the stuff like in the Gulf of Mexico. Then we get the lease payments and we get the royalties coming to the federal government. Our argument is put that in the highway trust fund, and that can help us fix our roads and our bridges problem. Minerals are a little bit different in mining, and that's something that keeps being negotiated. There are some old laws that need to be updated on how that works. Everybody has a different opinion on that issue. But the answer is yes, you get an original lease payment, and the federal government gets a royalty payment, and that comes in. And so my argument is, if we can open up, I don't know if you can see this or not, but this area here in the Intermountain region, between the Cascades and the Rockies and around the Rockies, most of that's federal land. And that's where we have huge basins of oil and natural gas, that if we tap those basins of oil and natural gas, dramatically drop our imports, create jobs, lower prices, more manufacturing, and more revenue through lease payments and royalty payments, in addition to the taxes coming into the federal government. So yes, that you do get money off it. Remind me, it was the lady there? Yeah.
Your first slide that you had up, I wonder if you could go back to it.
The debt one?
Yeah. All right. No, that one. You show that in 2011 we're at that bump.
Right.
But you indicated World War II. You did not indicate Afghanistan and Iraq, which went a long way toward that bump, moving us up. Except that those wars were not on budget. So are we on budget now with Iraq?
Yeah, so every time I write a budget, I actually put the war in the budget. The Bush administration did not. The Obama administration does. And our House budgets do.
Okay.
But those budgets, those wars are pretty much, Iraq's done. We're in the last year of Afghanistan. And so it is true that did contribute to the rising debt. But that is not what is contributing to this. This is the what we call mandatory spending program.
If we're not in war, if we're not at war in those places,
right?
Supposedly that bump should go down
So
first, and not just soar from that high point.
Right. So that's my point. Is what's pushing this up is this: Medicaid, Medicare, Social Security, and interest. See where we are right now. We are right about here. These numbers go up dramatically. Let me give you another way of looking at it. About 61% of the federal government is what we call mandatory spending. Automatic programs that if you qualify for the benefit, you get it. If you paid FICA taxes during your working years and you turn 65, you automatically get Social Security and Medicare. That's part of the social contract. The issue is we're doubling the amount of retirees using those benefits in one generation, and the costs of the programs go up between 6 and 8% a year. So that's pushing the numbers up to the point where these three programs, Social Security, Medicare, and Medicaid, plus interest, will consume 100% of all federal revenues by the year 2025, according to the Congressional Budget Office.
Oh my.
So that means no money coming in for anything else the government does. Education spending, defense spending, farm programs, veterans benefits, all of that will have to be on borrowed money. And so that is why they say this debt is going up massively. It's really, yes, deficits went down because of, actually this graph tells you the best story. So you're onto something, but it's a temporary reduction in deficits and debt because of the moment we were in. This tells you where spending went up and where revenues went down, basically during the recession, which coincided with wartime. Now, most of the reason for this spending increase was because of what we call automatic stabilizers, unemployment insurance, and things for benefits for people who are unemployed. And that's gone down, and war spending's gone down. So now we're back to sort of, big deficits, but not catastrophically high deficits. What the Congressional Budget Office is telling us is by 2018, deficits start going off again, and by the end of the decade, we're at $1 trillion deficits again, not because of war, but because of these other factors I mentioned. It's the aging of America, and it's the cost of health care, and we have to reform these programs as soon as we can. And the whole point I keep making on this is, the sooner we reform these programs, the more we can guarantee no change occurs to anybody who is in or near retirement. Like, look, Nancy Bell and my mom are in the same generation. Worked all of her life to pay these taxes because government made a promise to her that Medicare and Social Security would be there for her. That's the social contract, health and retirement security. We can keep guaranteeing it. But my generation, it won't be there for my generation, let alone, my kids' generation. So the question is, can we put reforms in place for the next generation so that we can cash flow the current generation? And the sooner we do that, the better we can guarantee these programs are there for everybody. But if we go to a debt crisis, if we ignore this problem, and this debt starts going up really high, and our interest payments start taking off on us, then we'll have a debt crisis just like Europe did. We'll have to cut spending indiscriminately across the board in real time. They're cutting benefits for seniors after they've retired over there. They're pulling the safety net out from under people. We want to prevent that from happening. And so our whole point of this is we've got to get a handle on these programs, and if we can reform these programs, we can do it prospectively. Doesn't affect people who are about to retire or who have already retired. It affects those of us who are younger. And by the way, if we reform it the way we're talking about, then we'll have something we can count on. Right now, I know that I'm facing a 25% benefit cut, no matter what, on my Social Security. And my kids, it won't be there for them. I know this. This is what the actuaries tell us. So the question is, can I reform the program so that it's there for us when we retire without making changes for you who have already retired or who are about to retire? And we can do that now. But if we wait, well, that's a much longer conversation. And go to my budgets. I've actually passed 3 budgets that do that. But
are you raising the FICA limit?
That's one of the ideas. So I'm saying there are other ways of doing it. Raising the FICA limit is one of the ideas that's been offered out there. There's plenty of ideas. The whole point is we got to get on with doing something. That's my argument. And so if we don't, then we'll have a crisis. Interest rates pop on us, and then we got to cut everybody. And we don't want to do that. It was the lady in what I thought was a jean jacket. Yeah.
Yes, sir. Thank you for taking my question. I'm a registered nurse. I work in cardiac and pulmonary rehab.
Wait, Mercy or Dean?
I work at Edgerton Hospital, it's a critical access hospital. And it kind of follows, my concern follows the lady who just spoke in regards to a suggestion that came from Dr. Berwick from CMS, looking for a technical correction in language that oversees, that covers cardiac and pulmonary rehab. And CMS has asked that Congress change the language that was written into the law in 2010 that says we are a physician supervised service.
Oh, right.
And we are a physician supervised service, but CMS would like to add physician extenders, and that means NPs and PAs who see you in the emergency room and diagnose your heart attack, who assist in surgery when you had your open heart surgery, who see you in the ICU, who discharge you, who see you in follow-up, but cannot see you in an outpatient stable setting. And it's because of the language, and we do have physicians as medical directors, we have physicians involved in each patient's plan of care.
Right.
But what we're looking for is physician extenders on that day-to-day basis. If I have a patient who's having a crisis, that I can go to an NP or PA.
Right.
And so that's a cost saving.
Yeah, so could I just get it clarified? So what you're saying is you're under physician supervision,
Correct.
but not necessarily in the episode of care that's occurring right now.
Correct.
And the goal is, can you allow non-physician trained people to implement care in those moments, right? That's what this is about,
Yes,
yeah.
sir. And so MIPA was passed in 2010, which was the update for cardiac and pulmonary rehab. And then CMS came back and said, we can't change it. We don't think that was the intent of the law.
That's right.
And so we do need that, and we've been asking for that, what we feel is a minor technical change.
Yeah, I met with some cardiologists in Milwaukee about this about a week ago.
Excellent.
Yeah.
So you're aware.
Do you have paper with you by chance?
I left it all with
Okay.
Allison Steele when I was
Yep,
in office
great.
last week.
Great, yeah. I met with some cardiologists. We thought that the law did this to begin with.
Right.
And we think CMS has the authority to do it, but I am familiar with the issue. And I think you're right. The whole point is making care easier to give.
Exactly.
And our fear is if this goes through as regulated, you won't have enough people delivering this care.
Well,
It will stretch our physicians too thin. That's the whole
exactly.
argument, right?
Which is why they're called physician extenders, and our programs help our patients become more independent, get back to work, reduce rehospitalization, so all of that's documented.
Okay, thank you. Hands, red, blue.